You ever feel like you want the cheat sheet to understanding something complicated? Like, just skip the textbook and give me the essential
Yeah,
insights. That's
absolutely.
exactly what we're up to today. We're diving into canine Cushing's syndrome, or, well, hyperadrenocorticism.
Mhm.
Think of it simply as a condition where a dog's body pumps out way too much of a stress hormone called cortisol.
And just to get right to the point, there are really two main ways this happens. We'll be focusing on what's called spontaneous Cushing's,
Okay.
where the dog's own system sort of goes haywire, and also iatrogenic Cushing's.
Iatrogenic, meaning caused by treatment.
Exactly. That's the one that happens when too much steroid medication is given.
Precisely. So our goal in this deep dive is to unpack, what triggers this excess cortisol,
Mhm.
what signs you might see in your dog,
Right.
how vets actually diagnose it, and the treatment options available. We've gone through the expert veterinary information to bring you the crucial knowledge.
The key takeaways, yeah.
So let's get started.
Okay, let's get right into the core of it then. Spontaneous hyperadrenocorticism, or spontaneous HAC, that basically means the adrenal glands.
The ones near the kidneys.
Yeah, those little glands, they're producing too much cortisol all on their own. Now, iatrogenic HAC is different.
Right, you said that's the medication one.
Correct. The term iatrogenic just means it's caused by medical treatment. So in this case, it's the overuse of strong anti-inflammatory drugs, glucocorticoids.
Whether pills, injections.
Any way they're given, yeah. If it's too much for too long.
And it's not just a little bit more cortisol. It's these constantly high levels that can really mess with the dog's body.
Yeah.
Right, affecting various systems.
Definitely. The clinical signs really stem from those harmful effects.
So what kicks off this overproduction in the first place? What's the underlying cause for the spontaneous kind?
So here's where it gets really interesting. For spontaneous HAC, we're mainly looking at two key reasons.
Okay.
The most common one, in about 80 to 85% of cases, is pituitary-dependent HAC. PDH for short.
Pituitary. That's the gland in the brain.
Exactly. A small but really important gland at the base of the brain. Think of it like the body's main control center for a lot of hormones.
Okay.
And what happens here is there's usually a tumor or sometimes just an overgrowth of cells in that pituitary gland.
And that causes problems how?
Well, these pituitary issues lead to the overproduction of ACTH. That's another hormone.
Right, ACTH.
And ACTH is the signal that tells the adrenal glands to produce cortisol. So if the pituitary is sending out way too much ACTH.
The adrenals just obey the command and make too much cortisol.
Precisely. So in these PDH cases, the adrenal glands themselves are usually healthy. They're just following faulty signals. And this causes both of them to get larger over time.
So it's like a faulty radio signal from the brain constantly telling the volume, the cortisol production, to go up, even when it shouldn't.
That's a great analogy, yeah.
Okay, so that covers the big chunk, the 80, 85%. What about the other 15 to 20% of spontaneous cases?
Right. In those instances, the problem usually lies directly with one of the adrenal glands itself.
Ah, so not the signal, but the gland itself.
Exactly. An adrenal tumor develops, and it starts pumping out cortisol without any prompting from the pituitary.
Okay.
And it's worth knowing that about half of these adrenal tumors can actually be cancerous, malignant.
Oh, wow. Okay.
And then in really, really rare situations, we might see something called ectopic ACTH secretion.
Ectopic, meaning out of place.
Yeah, where a tumor in a completely different part of the body, not the pituitary, starts producing ACTH, which, again, tells the adrenals to make too much cortisol.
That's unusual.
Very rare. And then, of course, as we mentioned, iatrogenic HAC is just from us giving too much steroid medication over a long period.
Okay, so we've got the why sorted. It's either a signal mix-up from that brain control center, an adrenal gland going rogue, or too much medication from the outside.
Pretty much, yeah.
So what does all this extra cortisol actually do to a dog? What are the signs that owners might notice?
Well, the effects of high cortisol are really widespread because cortisol has a finger in lots of different pies, so to speak, lots of bodily processes.
Right.
While every dog is different, you'll often find that problems with their urination and their skin are often the most obvious things you see.
Okay, urination and skin.
Yeah. And looking at their hormones and metabolism, we frequently see elevated blood sugar. And in around 10% of cases, this can even progress to full-blown diabetes.
That makes sense, yeah, given cortisol affects sugar use. What about things like their heart or appetite?
We might see a mild increase in blood pressure, potentially. And when it comes to their digestive system, a very, very common sign is a significant increase in appetite.
Polyphagia, right?
That's the term, yeah. These dogs often seem constantly hungry, ravenous even.
I've definitely heard about that never-ending hunger being a key thing people notice.
Yeah.
What about changes maybe in their blood work or affecting their immune system?
Good question. On blood tests, there's often a specific pattern of changes in their white blood cell counts. We call it a stress leukogram. And also that high cortisol can weaken their immune system, which makes them more susceptible to infections.
Right, that makes sense.
We might also see a slight increase in their red blood cells and platelets sometimes. And the liver. The liver often changes because it stores more glycogen, and we typically see a notable rise in a particular liver enzyme.
Which one is that?
Alkaline phosphatase, or ALP, it's often quite significantly elevated.
Okay, so those blood test results can offer some important clues then.
Yeah.
What about their muscles and how energetic they seem? Are they still active?
Muscle weakness is actually quite common. They might seem less energetic, more lethargic.
Okay.
And in rare situations, particularly if there's a large pituitary tumor pressing on things, we might even see signs affecting their brain.
Like what?
Things like a decrease in appetite, which is unusual given the usual hunger, uncoordinated movements, maybe confusion, and very, very rarely seizures.
Okay, that's serious. And you mentioned urination earlier.
Yes, absolutely. Increased urination and increased thirst, what we call polyuria and polydipsia, or PUPD, are present in about 90% of cases. It's a huge sign.
90%, okay. So lots of drinking, lots of peeing.
Definitely. And we might also find protein in their urine, or they might get more frequent urinary tract infections because of the weakened immune system and dilute urine.
Gosh, that's a lot of different areas being affected.
Yeah.
Are there any other, maybe less obvious things an owner might observe over time?
Yeah, there are a few more. Concerning their reproductive system, male dogs might experience testicular atrophy, a shrinking of the testicles,
Okay.
and females might stop having their heat cycles and estrus.
Right, and breathing.
Increased panting is common, even when they're resting. And there's a slightly higher risk, unfortunately, of blood clots forming, potentially in the lungs, which is called a pulmonary thromboembolism.
That sounds dangerous.
It can be, yes. And then the skin changes are often quite distinctive, as we mentioned.
It kind of changes.
Symmetrical hair loss, often starting along their back and sides, sometimes leaving the head and legs furry.
Okay, like a pattern baldness.
Sort of, yeah.
Hmm.
And you might see the appearance of blackheads, comedones. The skin itself might darken, called hyperpigmentation. And recurring skin infections are common too because the skin's defenses are down.
And those are the more specific signs linked to different body systems. What about just general things an owner might notice day to day, or perhaps something a vet might pick up during a checkup?
Exactly. Some general signs include that characteristic pot-bellied appearance.
Why does that happen?
It's usually a combination of muscle weakness in the abdominal wall and the liver getting larger, plus sometimes fat redistribution.
Ah, okay.
So that pot belly, the increased panting even when resting, an enlarged liver that a vet might feel during an exam.
Palpate, yeah.
Right. Skin that seems thinner, maybe more fragile, more easily damaged. Muscle loss, particularly over the back and legs.
Even if they're eating more.
Yes, sometimes they gain weight overall due to the appetite, but they still lose muscle mass. So obesity can happen alongside muscle wasting.
Interesting paradox.
It is. You might also notice they seem more tired or lethargic, maybe they bruise more easily, or develop small, hard calcium deposits in the skin that's called calcinosis cutis.
Okay.
And in very rare instances, facial nerve paralysis has been reported.
So it's a really, really wide range of potential indicators. It sounds like putting all the pieces together can be quite a puzzle for vets.
It definitely can be. Diagnosis isn't always straightforward.
Now, who typically gets Cushing's? Is it something we see a lot? And are certain types of dogs more prone to it?
It is indeed a fairly common hormonal or endocrine disorder in dogs, though getting exact numbers on how many dogs are affected overall is tough.
But common enough that vets see it regularly.
Oh, absolutely. And we do know that certain breeds seem to have a higher risk.
Which ones?
Poodles, especially miniature poodles, dachshunds, Boston Terriers, German Shepherds, and Beagles are often mentioned.
Okay. Any particular age group?
It most often affects dogs in their middle to older years. Think, 6 years and up, typically. Although, as we mentioned earlier, that pituitary-dependent type, PDH, can very rarely occur in younger dogs.
And what about males versus females? Any difference there?
Interestingly, for the pituitary-dependent HAC, we haven't really found a difference in how often it occurs in male versus female dogs. No sex predilection, we'd say.
Okay.
However, there might be a slight tendency for female dogs to be more prone to developing the adrenal tumors.
Ah, okay. And are there known risk factors, apart from breed and age, for the spontaneous kind, like lifestyle or diet?
For spontaneous Cushing's, not really. We don't know of any specific avoidable risk factors. It seems to be more about genetics and age-related changes.
But for the iatrogenic kind, the cause is the risk factor.
Exactly. For iatrogenic Cushing's, the risk is very clear. Any dog that needs to be on glucocorticoid medications, those steroids, for a long time for any other condition is potentially at risk.
Okay, that makes sense. So if an owner notices some of these signs, the drinking, the peeing, the pot belly, skin issues, how do vets go about figuring out if it's actually Cushing's? What's the diagnostic process like?
Right. Diagnosing Cushing's really involves looking at the whole picture. You take the clinical signs the owner is reporting.
The history.
Yes, the history. Then what we find during a physical exam, the results of their routine blood work and urine tests are often the first step.
The screening labs.
Exactly. And then, very importantly, specific hormonal tests are needed to confirm it. We also need to keep in mind other conditions that can sometimes mimic Cushing's.
Differential diagnoses.
Precisely. Things like hypothyroidism, other hormonal skin conditions, diabetes mellitus, sometimes liver or kidney disease, or even just age-related changes can cause similar signs like increased drinking or skin problems.
So those initial blood and urine tests you mentioned, they're just the starting point to help narrow things down. Or can they diagnose it?
They're more like clues, really. They help build suspicion, but they don't diagnose Cushing's on their own. Standard blood tests, like a CBC and a chemistry panel,
Okay.
might show some changes that make us think, could this be Cushing's? We might see that stress pattern in the white blood cells we talked about.
The stress leukogram.
Right. We often see those elevated liver enzymes, especially that high alkaline phosphatase, the ALP. High cholesterol is common too, and often a higher level of bicarbonate.
Bicarbonate, okay.
High blood sugar is common, but remember, only about 10% actually have full diabetes requiring insulin.
Got it. And the urine tests.
Urine tests might show that the urine is very dilute, low specific gravity, we call it. There might be protein spilling into the urine, proteinuria, and sometimes signs of a urinary tract infection like blood, pus, or bacteria because of that suppressed immunity.
Okay, so those initial tests can definitely raise a red flag. What are the actual hormonal tests that can tell us more definitively if Cushing's is present? The screening tests.
Great question. There are 3 main screening tests we typically use to see if the dog likely has Cushing's.
3 options.
Generally, yes. The first is the urine cortisol creatinine ratio, or UCCR.
How does it work?
It measures the amount of cortisol in a urine sample collected at home, ideally first thing in the morning, compared to creatinine, which is just a normal waste product.
Okay.
If there's a lot of cortisol relative to creatinine, it could suggest Cushing's. This test is very sensitive,
Meaning?
meaning if the result is normal, it's really unlikely the dog has Cushing's. It's good at ruling it out.
Okay, so a negative is pretty reliable.
Yes. However, it can have a lot of false positives. Other stresses or illnesses can cause a high UCCR. So a high result on its own isn't enough for a diagnosis. We always need to confirm it with another test.
Got it. So a normal result is reassuring, but a high one just means keep digging. What's the next screening test option?
That would be the low-dose dexamethasone suppression test, or LDDST.
Okay, dexamethasone, that's a steroid, right?
It is. It's a synthetic steroid similar to cortisol. In this test, we give the dog a very small, standardized dose of dexamethasone, usually by injection.
In that.
And then we measure their own cortisol levels in their blood at specific time points afterwards, typically at 4 hours and 8 hours.
What should happen?
In a healthy dog, that small dose of dexamethasone should signal their pituitary gland to stop producing ACTH for a while, which in turn tells the adrenal glands to stop producing cortisol. So their cortisol level should drop or suppress.
Okay. And in a dog with Cushing's?
In a dog with Cushing's, this suppression either doesn't happen properly or it doesn't last the full 8 hours. Their cortisol levels stay high.
Ah.
It's another sensitive test, good at picking up cases. But again, other non-adrenal illnesses can sometimes interfere and cause a false positive result.
So context is important.
Always. Interestingly, the pattern of cortisol levels during an LDDST, like if it suppresses at 4 hours but bounces back up by 8 hours, can sometimes give us a hint that it might be the pituitary-dependent type, PDH, but it's not definitive for differentiation.
That's really helpful information, though. And the third screening test, what's that one?
That's the ACTH stimulation test. sometimes called an ACTH stim test.
Okay, ACTH. That's the hormone that tells the adrenals to make cortisol.
Exactly. So for this test, we first take a baseline blood sample to measure their resting cortisol level. Then we give an injection of synthetic ACTH.
You're stimulating the adrenals on purpose.
Precisely. And then we take another blood sample, usually an hour later, to see how much the cortisol level has increased in response to that stimulation.
What do you expect to see?
In a normal dog, we'll see a moderate, predictable rise in cortisol. But in a dog with spontaneous Cushing's, their adrenal glands are already sort of primed and enlarged, working overtime.
So they overreact.
They tend to have a much larger, exaggerated increase in cortisol after the ACTH injection. This test is generally considered a bit more specific than the LDDS2.
Meaning fewer false positives.
Generally, yes. Although its sensitivity might be slightly lower, meaning it might miss a few cases the LDDS2 would catch. And crucially, the ACTH stimulation test is the only test we can use to diagnose iatrogenic Cushing's.
Ah, the one caused by steroid medication. How does it show that?
Because in those cases, the dog's own adrenal glands have been suppressed by the long-term external steroids. They've kind of gone dormant. So when you give them the ACTH injection, their cortisol level barely budges. It stays very low or shows a very weak response.
That makes perfect sense. Low response, likely iatrogenic if they have a history of steroid use. The high response, imparti spontaneous Cushing's.
You got it. That's the general idea for screening.
Okay, so let's say we've used one or maybe a combination of these screening tests, and we're pretty confident the dog does have spontaneous Cushing's.
Right.
What's the next step? How do we figure out if it's a pituitary type, PDH, or if it's an adrenal tumor, AT?
Right. That's the crucial differentiation step. Because the treatment and prognosis can differ, this is where what we call differentiation tests come in.
Okay, what are those?
One option is the high-dose dexamethasone suppression test. It's similar in principle to the low-dose test.
The LDDST.
Yes, but this time we use a much larger dose of dexamethasone. The thinking is that this higher dose might be enough to overcome the resistance in some pituitary tumors and cause suppression of cortisol.
But maybe not enough for an adrenal tumor.
Exactly. In many dogs with pituitary-dependent HAC, maybe around 75%, this higher dose will actually be enough to suppress cortisol production, at least partially. Whereas in dogs with adrenal tumors, which are acting autonomously, the high dose usually won't cause suppression. That cortisol stays high.
So if it suppresses on the high-dose test, it strongly suggests pituitary PDH.
It does. However, a lack of suppression on this test doesn't definitively mean it's an adrenal tumor. About 25% of PDH cases don't suppress even on the high dose.
Okay. So it can point towards PDH, but it can't reliably confirm AT.
Correct. It's not perfect for ruling in AT.
So what other tests can help us differentiate that?
You also have the endogenous ACTH concentration test, or ECTA.
Endogenous meaning the dog's own?
Yes, exactly. This test directly measures the level of ACTH hormone that the dog's own pituitary gland is producing and circulating in the blood.
How does that help tell PDH from AT?
Well, think about it. In dogs with pituitary-dependent HAC, the pituitary is the source of the problem. It's overproducing ACTH. So their ECTH level is usually normal or often high.
Makes sense.
But in dogs with adrenal tumors, the tumor itself is making cortisol independently. That high cortisol then sends negative feedback to the pituitary.
Telling it to chill out.
Right, telling it to produce less ACTH. So in dogs with adrenal tumors, the eACTH level is typically low, sometimes undetectable.
Ah, that seems quite clear-cut. High ACTH points to pituitary, low ACTH points to adrenal tumor.
It can be very helpful, yes, especially for confirming an adrenal tumor if the ACTH is low. But sometimes the results fall into a kind of middle, gray zone, or overlap range. And the sample handling for this test is also very critical to get accurate results. So sometimes we might need to repeat the test or use it alongside other information.
Okay, so blood tests are clearly really key in figuring this all out. What role does imaging play, like X-rays or ultrasound?
Imaging is extremely useful, often essential for differentiation and staging, especially if we suspect an adrenal tumor.
How so?
Well, regular abdominal X-rays can sometimes help us actually see adrenal tumors, especially if they contain mineral deposits, calcification. That's a strong indicator of a tumor, often malignant.
Okay.
And chest X-rays are also often recommended if we suspect an adrenal tumor to check if cancer might have spread to the lungs, which is unfortunately common with adrenal carcinomas.
Right, checking for metastasis. What about ultrasound?
Abdominal ultrasound is probably the most commonly used imaging tool here. It lets us look directly at the adrenal glands.
What are you looking for?
We're looking at the size and shape of both glands. In pituitary-dependent HAC, because both glands are being overstimulated by ACTH, we usually see bilateral adrenal enlargement. Both glands are bigger than normal, but often roughly symmetrical.
Okay, both enlarged, likely PDH.
Generally, yes. Whereas if there's an adrenal tumor, we typically see one adrenal gland that's enlarged, maybe distorted or irregular in shape.
The one with the tumor.
Right. And the other adrenal gland often looks normal or might even be smaller than normal, atrophied, because its stimulation from ACTH has been suppressed by the cortisol from the tumor.
Ah, okay. So asymmetry is a big clue for an adrenal tumor.
It is. Ultrasound can also help us look for signs of the tumor invading nearby structures, like blood vessels, which can affect prognosis and surgical options.
Are there limitations to ultrasound?
Yes. It's highly operator dependent, and it can't reliably be used as a screening test on its own. Finding enlarged adrenals doesn't automatically mean Cushing's, as other things can cause that. Plus, very small adrenal tumors might be missed.
So it's best used after hormonal tests suggest Cushing's to help differentiate.
Exactly. And then there are more advanced imaging techniques like CT scans and MRI.
What do they offer?
CT and MRI give us much more detailed images. They're particularly good for assessing the extent of adrenal tumors, looking for invasion, and planning surgery. They can also visualize the pituitary gland itself much better than ultrasound or X-ray, helping us detect larger pituitary tumors, macrodenomas.
So quite a comprehensive imaging toolkit available.
Yes, depending on the case and what questions need answering. Some specialists even recommend routine MRI of the pituitary in all dogs diagnosed with PDH to check for those larger tumors.
And if a tumor is found, say, in the adrenal gland, how do vets definitively determine if it's benign or cancerous?
Ultimately, the only way to know for sure if an adrenal tumor is benign, an adenoma, or malignant, a carcinoma, is by examining the tissue itself under a microscope after it's been removed surgically. That's histopathology, usually done via a biopsy of the removed mass.
Okay, so diagnosis involves clinical signs, basic labs, specific hormone tests, and often imaging to put it all together.
That's a good summary, yes.
So we've covered how we figure out what's going on, just briefly. What's actually happening inside the body at a cellular level in these different forms?
Yeah.
What would a pathologist see if he looked at the tissues?
Sure. With pituitary-dependent HAC, the PDH type, when we look at the tissues, we'll usually see a pituitary gland that's maybe normal in size or enlarged. Microscopically, we'd find either a benign tumor, an adenoma, which is most common,
Okay.
a rare cancerous tumor, an adenocarcinoma, or sometimes just an increased number of the normal ACTH-producing cells called hyperplasia.
And the adrenal glands in PDH.
Both adrenal glands will be larger than normal, showing diffuse hyperplasia, meaning an increase in the number of cells in the adrenal cortex, the outer part that makes cortisol, because they're being constantly stimulated by that excess ACTH.
Makes sense. And in contrast with an adrenal tumor, AT.
With AT, we'll find a distinct mass, a tumor, in one of the adrenal glands. This could be variable in size. And critically, the other non-tumorous adrenal gland will often be smaller, atrophied, because it's not getting that ACTH stimulation.
Right, due to the negative feedback.
Exactly. Microscopically, the mass will be either a benign adrenal adenoma or a cancerous adrenal carcinoma. And if it's a carcinoma, we might see evidence of it spreading to nearby tissues or distant sites.
And are there any general changes seen regardless of the type?
Yes. Regardless of the underlying cause, the long-term effects of high cortisol can lead to general changes like thinning of the skin, which we call epidermal atrophy, and sometimes specific changes in the kidneys too, like glomerulosclerosis.
Okay, so we understand the what and the how of diagnosis and what's happening internally. Now let's talk about the really practical part.
Yeah.
What can be done about it? What are the treatment options for canine Cushing syndrome?
Right, treatment. The best approach really depends on several factors. How severe the dog's symptoms are, their overall health, their age, and if they have any other concurrent health issues going on like diabetes or kidney disease or blood clots.
So it's individualized.
Very much so. And importantly, in most cases, we don't usually need to make major changes to their activity level or their diet, unless, of course, they also have diabetes, which would need dietary management.
Okay. What's crucial for owners to know up front?
I think it's really important for owners to understand that if we opt for medical management, using medication, it's almost always a lifelong commitment.
Lifelong therapy.
Yes. And with that comes the need for regular monitoring, follow-up vet visits, and blood tests. Owners also need to be educated on how to recognize potential side effects of the drugs and know when to get in touch with their vet immediately. Compliance is key.
Good point. What about surgery? Is that often an option?
Surgery plays a role, but it depends on the type of Cushing's. Surgically removing the pituitary tumor, a hypophysectomy.
The brain surgery.
Right. It is an option and can be curative for PDH, but it's a highly specialized procedure and isn't widely available. It's usually only done at certain university hospitals or specialty centers.
So not a common choice for most PDH cases.
Not for most, no. And removing both adrenal glands, a bilateral adrenalectomy, is generally not recommended or used for treating PDH either, due to the high risks and the need for lifelong hormone replacement afterwards.
Okay. So surgery is more relevant for...
For the adrenal tumors, 8T surgery to remove the affected adrenal gland, an adrenalectomy, is often the preferred treatment for benign adrenal adenomas and also for smaller adrenal carcinomas that haven't spread significantly.
if the dog is otherwise healthy enough for surgery.
Exactly. As long as the dog is a reasonably good surgical candidate and the owners are prepared for what is a complex surgery with potentially intensive aftercare, including managing hormone levels post-op.
What if the tumor is more advanced, maybe invading blood vessels?
Even if an adrenal tumor has spread locally or is involving major blood vessels like the vena cava, surgery to remove as much of the tumor as possible, sometimes called debulking, can sometimes extend the dog's life and improve quality of life, although it might not be a complete cure in those cases.
And do you sometimes treat with medication before surgery?
Yes, in some situations, particularly if the dog is quite sick from the Cushing's, we might use medication for a period first to get the cortisol levels under better control and make them a safer candidate for anesthesia and surgery.
Okay, so surgery is focused mainly on adrenal tumors, and pituitary surgery is rare. That means medication is the mainstay for most dogs, especially those with PDH.
That's correct. Medical management is the most common approach overall, particularly for the 80–85% of dogs with pituitary-dependent HAC.
So what are the main drugs used? You mentioned a couple earlier.
Yes, we have several medications available. One of the long-standing treatments is mitotane, also known by the brand name Lysidrin.
Mitotane, how does that work?
Mitotane works by selectively destroying the cells in the adrenal cortex that produce cortisol. It essentially causes necrosis or death of those specific layers.
Wow, it actually destroys the cells.
It does, and interestingly, it can sometimes even have a similar effect on adrenal tumor cells, potentially killing tumor cells in some cases, which is why it's used for both PDH and sometimes inoperable AT, or after surgery for AT.
Sounds potent. Does it require careful handling?
Absolutely. Using mitotane requires very careful monitoring, primarily with ACTH stimulation tests. We need to make sure we're reducing the cortisol production to the desired level, but not going too far and causing Addison's disease, which is too little cortisol.
Like opposite problem.
Right. There are specific protocols for an initial loading phase to get the cortisol down and then a lower maintenance dose long term. These dosages are adjusted based on the results of those ACTH stimulation tests and the dog's clinical signs.
Any major side effects to watch for?
Potential side effects can include lethargy, vomiting, diarrhea, or loss of appetite, which might indicate the cortisol is getting too low. There's also a possibility, though less common, of it affecting aldosterone production, which is another crucial hormone made by the adrenals that regulates electrolytes.
So really precise monitoring and owner vigilance are essential with mitotane.
Definitely.
What's the other main medication that's commonly used now?
That would be trilostane, often known by the brand name Veterinary. It's licensed for treating Cushing's in dogs in many countries, including the US and Europe.
Trilostane, how is it different from mitotane?
Trilostane works differently. Instead of destroying the cells, it works by inhibiting or blocking a key enzyme.
An enzyme.
Yes, an enzyme called 3-beta-hydroxysteroid dehydrogenase, which is necessary for the production of cortisol within the adrenal gland. It also affects aldosterone production to some extent.
So it blocks production rather than killing the factory.
That's a good way to put it, yes. It reversibly inhibits hormone synthesis. It's been shown to be similarly effective to mitotane for managing the clinical signs of pituitary-dependent HAC.
And how is it dosed and monitored?
The dosage is also determined and adjusted based on ACTH stimulation tests as well as clinical signs. And it's really important with trilostane to get the timing of the blood sample right for that ACTH stim test. Yes, the blood sample for the post-ACTH cortisol level needs to be collected at a specific time window after the dog has received its trilostane pill, usually 4 to 6 hours post-pill, to accurately assess the drug's effect at its peak.
Okay, that's a key detail for owners and vets. Does trilostane have side effects too?
Yes, it can. Similar to mitotane, if the dose is too high or the dog is sensitive, it can lower cortisol too much, leading to signs like lethargy, weakness, vomiting, or diarrhea. And because it also affects aldosterone, there's a risk of an Addisonian crisis that's a potentially life-threatening state of low cortisol and low aldosterone.
So it still requires careful monitoring.
Absolutely. There's also been some debate and evidence suggesting that in rare cases, trilostane might lead to adrenal necrosis or damage, though the mechanism isn't fully clear.
Can trilostane be used for adrenal tumors too?
It can sometimes be used off-label to help manage the symptoms of an adrenal tumor, especially if surgery isn't an option. But because mitotane has that potential to directly kill tumor cells, mitotane is generally considered the preferred medical treatment for adrenal tumors if you're aiming for more than just symptom control.
Okay, so mitotane and trilostane are the two big players for medical management. Are there any other medications that might be used in certain situations?
Yes, there are a couple of others, though used less commonly now. There's leldeprynol, also called salicylic hydrochloride, brand name Anapril.
Eldeprynol, what's that one for?
It's actually licensed specifically for treating uncomplicated pituitary-dependent HAC. It's thought to work more centrally on the pituitary gland, possibly by influencing dopamine levels to decrease the release of ACTH.
So it targets the signal source.
Theoretically, yes. However, its actual effectiveness has been quite debated. Some studies show pretty limited success rates compared to mitotane or trilostane. It's really only considered for mild, uncomplicated PDH cases without other issues like diabetes, and it definitely can't be used for adrenal tumors.
How do you monitor it?
Monitoring for eldeprynol is based mainly on observing if the dog's clinical signs, the drinking, panting, appetite, etc., are improving. There isn't a reliable blood test to monitor its effect directly. Side effects are usually mild and uncommon, maybe some restlessness or digestive upset.
So maybe an option for very specific mild cases, but not a first-line choice usually?
Generally, no. And then there's ketoconazole.
Ketoconazole. Isn't that an antifungal drug?
It is primarily, yes. But at higher doses, it also happens to inhibit several enzymes involved in steroid production, including cortisol synthesis in the adrenal glands.
So another production blocker, like trilostane.
Sort of, yes, but less specific. It's occasionally used as an alternative, maybe if a dog can't tolerate mitotane for some reason. We still need to monitor its effect with ACTH stimulation tests.
Is it very effective?
Its success rate is generally considered lower than mitotane or trilostane, maybe around 50% or even less show a good response. And it can have potential side effects, particularly gastrointestinal upset and potential liver toxicity. So liver enzymes need monitoring too.
Okay, so more of a backup option again.
Pretty much. Mitotane and trilostane are definitely the primary medical choices for most cases.
It sounds like there are quite a few options, but each really requires careful thought and that close monitoring. Are there any general things to absolutely avoid or be extra careful about when a dog has Cushing's? Maybe things that interact badly.
Yes, that's a really important point. One key thing is that it's generally not recommended to give nonsteroidal anti-inflammatory drugs, NSAIDs.
Like carprofen or meloxicam.
Exactly, those common arthritis drugs. They shouldn't ideally be given to dogs with Cushing's disease that isn't well controlled yet. There seems to be an increased risk of gastrointestinal ulcers or other complications when both conditions are present.
Good to know. Anything else?
We also need to be generally careful when using other medications that can affect blood pressure or blood clotting, as Cushing's itself can predispose dogs to high blood pressure and clots.
Okay.
And then for each specific Cushing's medication, there are additional precautions listed. For example, as I mentioned, mitotane and trilostane should be used with caution in dogs that already have significant kidney or liver problems.
Right.
Trilostane specifically should not be used in pregnant dogs. And if a dog with Cushing's also has diabetes mellitus.
You mentioned that earlier.
Yes, we need to be incredibly vigilant with monitoring their blood sugar and insulin needs, especially when starting Cushing's treatment. As the cortisol levels come down, their sensitivity to insulin can increase quite dramatically, and their insulin dose might need to be reduced quickly to avoid dangerously low blood sugar hypoglycemia.
Wow, okay. That requires very close collaboration between the owner and the vet.
Absolutely critical.
What about other types of treatment? Is something like radiation therapy ever used?
Yes, radiation therapy can be an important treatment option, specifically for dogs with large pituitary tumors, microadenomas, or macrotumors.
Ones that might cause neurological
Or
signs.
exactly, or are just found to be very large on imaging like CT or MRI. Radiation therapy directed at the pituitary gland is the primary treatment to try and shrink that tumor or stop its growth.
Does it work quickly?
It can take time. It might take several months for the radiation to have its full effect and for the ACTH levels produced by the tumor to decrease significantly.
So what do you do in the meantime?
Because of that delay, we usually need to use medical management concurrently using mitotane or trilostane to help control the Cushing symptoms while we're waiting for the radiation to work.
Okay, so radiation for big pituitary tumors, often alongside medication initially.
That's the usual approach, yes.
So once a dog starts getting treated, whether with medication or maybe after surgery, what does their life look like going forward? What kind of follow-up is necessary, and what's the overall outlook for these dogs?
Right, the follow-up and prognosis. Careful monitoring, as we've stressed, is really key to successfully managing Cushing's long-term.
Those ACTH stim tests again.
Yes, for dogs on mitotane, ketoconazole, or trilostane, we need to perform regular ACTH stimulation tests to assess how well the medication is controlling their cortisol levels.
How?
The frequency depends on the specific drug, the dose, and how stable the dog is. Initially, after starting treatment or changing a dose, the tests might be needed quite frequently, maybe every few weeks. Once they're stable on a maintenance dose, it might stretch out to every 3, 4, maybe 6 months, depending on the vet's preference and the dog's situation.
And remembering that specific timing for trilostane monitoring.
Crucially important, yes, that 4 to 6 hour post-pill timing for the ACTH stim test with trilostane. For aldapunil, remember, since we don't have those blood tests to monitor it directly, we rely heavily on the owner's observations of whether their dog's clinical signs are improving or staying controlled.
What signs should improve?
The goal of treatment, really, is to see those Cushing's-related signs. The excessive drinking, urination, appetite, panting, skin issues, lethargy gradually get better. This usually happens over a period of days to weeks to maybe even a few months for some signs like hair regrowth.
So improvement in quality of life is the main goal.
That's the primary goal, yes. We're aiming for control of clinical signs with minimal side effects from the medication.
Now, can Cushing's be prevented in any way? Or avoided?
For the spontaneous kind, the PDH or AT, unfortunately, there's no known way to prevent it from developing in the first place. It seems to be just something that happens, possibly with genetic links in some breeds.
So just vigilance.
Yes, the best thing we can do is be aware of the signs, especially if you have a breed that's known to be more predisposed, and seek veterinary advice promptly if you have any concerns. Early diagnosis and treatment generally lead to better outcomes.
And for the iatrogenic kind?
Well, that one is potentially preventable, or at least the risk can be minimized. The key is judicious use of steroid medications, using them only when necessary, at the lowest effective dose, and for the shortest duration possible to control the underlying condition they're being used for, and exploring alternative therapies if long-term anti-inflammatory treatment is needed.
Makes sense. And once a dog is being treated for spontaneous Cushing's, how do you prevent recurrence?
Consistent medication administration as prescribed by the vet and sticking to that schedule of regular checkups and monitoring tests are absolutely crucial to keep the cortisol levels controlled and prevent the Cushing symptoms from coming back or worsening.
Okay. What are some of the potential longer-term problems or complications that can still arise even when a dog is being treated for Cushing's?
Even with treatment, some dogs can still be prone to certain complications. These can include persistent high blood pressure, which might need separate medication.
Right.
Protein leaking into the urine, proteinuria, can sometimes persist or develop. Recurrent infections, especially urinary tract infections or skin infections, can still be an issue because the immune system might not fully recover.
Right.
Some dogs with Cushing's are also more prone to developing certain types of urinary stones, particularly calcium oxalate stones.
So stones, okay.
The development or worsening of diabetes mellitus is also a possibility. That increased risk of blood clots, thromboembolism, might persist to some degree. And of course, if they have a large pituitary tumor, there's always the risk of neurological issues developing or progressing.
So ongoing vigilance for these things is needed too.
Yes, regular health checks should include monitoring for these potential complications.
And finally, wrapping up, what's the general course of the disease likely to be, and what's the expected outcome, the prognosis for dogs diagnosed with Cushing's?
Okay. If Cushing's syndrome is left untreated, it's generally considered a progressive condition with a poor long-term outlook. The constant excess of cortisol takes a toll on the body, damaging various organs and making the dog more vulnerable to serious infections and other problems. Quality of life usually declines.
But with treatment,
With appropriate treatment, particularly for the common pituitary-dependent HAC, the prognosis is usually quite good, especially in terms of quality of life improvement.
what about lifespan?
The average survival time reported in studies for treated PDH is often around 2 years, maybe 2.5 years, but that's just an average. Many dogs can live much longer, sometimes for many years, enjoying good quality life.
So treatment makes a big difference.
A huge difference. Interestingly, many dogs who survive longer than about 6 months after being diagnosed and starting treatment often end up passing away eventually from other age-related illnesses common in older dogs, rather than the Cushing's itself, assuming it stays well controlled.
That's actually quite positive.
Yeah.
What about the less common scenarios?
The prognosis for dogs with those large pituitary tumors, macrotumors, especially if they're already causing neurological signs, is unfortunately less favorable, poor to grave often. However, if they have a large tumor without severe neurological signs yet, radiation therapy combined with medication can offer a fair to good prognosis for controlling signs and slowing progression.
And the adrenal tumors?
For benign adrenal tumors, the adenomas, that can be completely removed surgically, the prognosis is generally good to excellent. They can potentially be cured.
Great. And the cancerous ones?
For malignant adrenal tumors, the carcinomas, the outlook is more guarded and depends heavily on factors like the tumor size, whether it's invaded locally and whether it has spread, metastasized at the time of diagnosis.
Right.
If it's a smaller, non-invasive carcinoma that's surgically removed, the prognosis can still be fair to good overall, better with surgery plus maybe mitotane afterwards. For larger, invasive, or metastatic adrenal carcinomas, the prognosis is generally poor to fair, but sometimes even high doses of mitotane can lead to surprisingly good responses and prolonged survival times in some individuals.
So there's still hope, even in some difficult cases.
There can be, yes. It really highlights the importance of accurate diagnosis, staging, and individualized treatment planning.
Okay, so just to kind of wrap this all up and summarize, canine Cushing syndrome is, well, it's a complex condition. It's caused by too much cortisol.
Right, that hormonal imbalance.
And it happens either naturally because of issues with the pituitary gland or the adrenal glands themselves. It's spontaneous Cushing's.
Mostly PDH, sometimes AT.
Or it can be iatrogenic,
Huh.
resulting from too much steroid medication given for other things.
Correct.
The signs we see can vary quite a bit, affecting loads of different body systems, urination, skin, appetite, energy, muscles.
A very wide range, yeah.
And getting an accurate diagnosis isn't always simple. It involves putting together that whole clinical picture, the signs, the exam findings, the routine lab work,
Which raised suspicion.
and then using those specific hormonal tests like the LDDST or ACTH stem, maybe the UCCR,
For screening tests.
to not only confirm the diagnosis, but also with further tests like high-dose DEX or ECTH, plus imaging
Ultrasound, CT, MRI.
to figure out the underlying cause, pituitary versus adrenal tumor.
That differentiation is key for treatment planning.
And thankfully, we do have a range of treatment options available, mostly medications like mitotane and trilostane being the mainstays.
Especially for PDH.
And in some cases, surgery, particularly for those adrenal tumors, or maybe radiation for large pituitary tumors. And that careful ongoing monitoring, those regular vet visits and blood tests are just absolutely crucial for managing the condition effectively and helping these dogs have a really good quality of life.
Exactly. And hopefully, by understanding these key aspects, you, our listener, are now better equipped to have those informed discussions with your own veterinarian if you ever have concerns that your dog might be showing some of these signs.
Yeah, absolutely. And it really makes you think, doesn't it? I mean, considering how finely tuned the whole hormone system, the endocrine system is.
It really is intricate.
And how easily it seems it can get out of whack, like with Cushing's. It makes you wonder, what other subtle hormonal imbalances might we sometimes be missing in our pets?
That's a fascinating question.
And, how crucial is just our careful daily observation of their health and their behavior in potentially catching these things early on.
Observation is so, so important. Owners often notice subtle changes first.
Definitely something to ponder. Well, thanks for taking this deep dive with us today into canine Cushing syndrome.
My pleasure. It's a complex but important topic.